Good evening. Welcome to tonight's webinar on the MiniMed 670G system with SmartGuard Auto Mode technology. Tonight we have Sarah Glastris, practicing endocrinologist and clinical researcher at the Royal North Shore Hospital in Sydney. She also consults in a busy private practice. Hi, Sarah.
Hi, Sonia. Thanks for having me.
Sarah is also a senior lecturer at the University of Sydney. Her research studies are in the areas of diabetes and obesity, with a special interest in pregnancy. Sarah is a consultant for Medtronic, and we thank her for her time tonight.
Great. Well, thanks very much, Sonia. So we're going to kick off. I'm going to talk to you about the 670 pump and the hybrid closed loop system and how we can all start using it. So I'll take you to this study that was performed in 2013, the Type 1 Diabetes Exchange Registry, which really included a whole lot of patients with Type 1 diabetes. In fact, over 26,000 patients from 67 sites throughout the world, mostly the US. You can see there some data that I think is not too surprising for most people. You can see that the HbA1c across different age groups really centres around sort of 7.5 to 8%, with this big hitch up here that you see in teenage age groups, which I think is what we would all expect. And then you've really got a survival benefit here of patients who are surviving into their 70s and actually into their 80s with better HbA1cs, as you might expect. Now, the thing is, we often think, well, look, if we can't get a really good HbA1c, at least we can be happy that hypoglycemia isn't happening all the time. However, this study surprises us in that really, regardless of the HbA1c level that you reach, whether that be really good at less than 6% or way up here at sort of above 9, 10, 11%, there's still quite a big risk of hypoglycemia, somewhere between the ranges of 6 to 9%, and that's some data over 3 months. So it's a problem, isn't it? So we've got problems with HbA1c, we've got problems with hypos. So really, when we're thinking about patients with type 1 diabetes, what really do we want to target? And I think a good way of looking at things is really from the time in range point of view. So how often are we actually getting patients in the target zone that they want, so they can get a good HbA1c and they're not having lots of hypos and not lots of high blood glucose levels either. Okay, so here's a profile of one particular patient looking at 4 different nights. So just focusing your attention up on where the line is in the top panels here, you can see that one night glucose levels are driving along nicely, is pretty reasonable, almost at that sort of median level that you might like. Night 2 is not too bad as well, but night 3 levels go up, and in fact night 4 begins the night at a very low blood glucose level. And so when you pick up on what sort of insulin requirements you would want for those different 4 nights, you can actually see, how about that? There's in fact quite different insulin profiles that you would really need to get a nice flat glucose profile overnight. So you've got a problem there, because if you're using just a simple basal insulin once a day, like Levemir or Lantus, Protophane, these sorts of things, the problem is there's no way you'll ever get to that nice kind of flat profile overnight. And in fact, even if you've got an insulin pump that you can change every hour or even every 5 minutes, unless you can make it do a different rate every single night at a different kind of level, you're never going to be able to get a good profile that actually is going to keep you in a nice tight range. So this brings me to the hybrid closed loop pivotal trial. So this is really the cardinal studies that have looked at the MiniMed 670G pump with the continuous glucose monitoring. How does it perform? How can this pump actually achieve this hybrid closed loop and bring time in range to a decent level? So we've got quite a lot of patients enrolled in these studies from 10 different sites across the world, mostly the US, 2 different age groups, those that are essentially adolescents and adults, and then a childhood population as well. They all got type 1 diabetes, obviously, and have to have had diabetes for a little while, so they're not really in that sort of early honeymoon period. And their HbA1cs had to be decent before they started. And furthermore, they had to have already had some experience with insulin pump therapy. Interestingly enough, about 60% of patients had had some continuous glucose monitoring experience too. So in this study, the participants were had a run-in period where they just became familiar with the pump and the continuous glucose monitoring system for 2 weeks. Then their pump was then turned to auto mode, which is this hybrid closed loop system. And after 5, 6, 7 days of the auto mode learning, then the study period continued for the following 3 months. Now, this wasn't a study period where they were in a hotel or a hospital setting where the food was, given to them and dictated. This was a real kind of experience study whereby patients could take their insulin pump and 670 system home with them and do what they normally do and see what the outcomes would be. So with respect to time in range, how did the participants perform? Well, this is the data on the adults, first showing you on the left panel here, the day and night values, and then in this panel over here, just the nighttime timing. So with respect to what's important here, 88% of adults and 75% of adolescents were actually using the auto mode during that 3-month period. So pretty good adherence. In terms of the time in range, if you compare the run-in phase to the study phase, you see, look at that, you're actually getting quite a lot more time in range when you're in the auto mode versus when you're off the auto mode. And importantly, during the nighttime, you've really increased that up to 75% of time in range. Now, of course, hypoglycemia is important to us as clinicians. It's obviously important to patients and their family. And you can see that the hypoglycemia rate was significantly reduced and importantly reduced by more than half overnight. Severe hypoglycemia also reduced here, and these are statistically significant results for the time in range and hypoglycemia data. Now looking at the children between those aged 7 to 13 years, the time in range is not quite as high as what you see in adulthood. Again, probably not too surprising to us, but again, those rates have really increased in terms of how often participants are in time in range. And hypoglycemia, again, as in with the adults, has reduced significantly. If you compare here in these graphs just those different age groups, this is the orange colour is the run-in phase, those 2 weeks where they were not on auto mode. And then across the board there, you can see that once auto mode is applied, that time in range is significantly narrowed. Importantly, I just want to point out that it's not one continuous straight line. So if patients and clinicians are thinking by being on the 670G, it's going to be one continuous straight line the entire time, that is just not realistic. HbA1c, well, we care about that. Perhaps we should all be moving to time in range and thinking less about A1Cs, in my opinion. But if you want to look at A1C data, you can see that with the auto mode, you've significantly reduced your A1C by 0.5% in adults and adolescents, and almost the same in children. Of course, again, pointing out that this was the run-in phase in the blue this time, and in the orange is the end of the study. So everything's shifted there to the left. However, we've still got some patients who have a higher HbA1c. So again, I think having clear expectations, if you've got somebody with an HbA1c of 8.5, 9%, you're not going to move them to 6.5 or 7% after just 3 months. That's going to take quite a lot of time with working on behaviour and all sorts of other things. So in terms of the study strengths, this was a well-designed study. It was over a good 3-month period. It was an unsupervised in-home study, which I think reflects what we would generally be seeing with our patients. It was multi-centre, included all different age groups. And the study really supports safety. The hypoglycemia risk in the patients who were on the auto mode for that 3 months was very, very reassuring. Of course, got to remember that with any study like this, you can't double blind or randomise to a pump versus no pump. That of course doesn't really work. So this is a single arm, non-randomised study design. And you might say, well, look, the run-in phase was only 2 weeks and the study phase was 3. So there's a bit of difference there. And of course, exclusion criteria, you couldn't have an HbA1c above 10%. If you had a DKA in the last 6 months, that would exclude you as well. So there was obviously some study criteria that you have to consider and then and work out whether the 670G pump is right for your patients. Okay, so if you then look at some real world data, so this is taken from CareLink. So now we're comparing really the pivotal studies to what we actually are seeing in the real world. And when you do that, you see, okay, that's quite interesting that in fact, in manual mode, it really is quite similar to what the run-in phase was for the pivotal studies. Around 63 to 66% of the time, patients, when they're not in auto mode, are actually in time in range here in the green. Whereas when you look on auto mode, that significantly increases, as we saw in the pivotal studies, 72% for the adults and 65% for the kids. Real world studies pushing it up to 70 to 75%. So again, showing again in the red there, hypoglycemia risk is also very, very low. So that's good news that really when you roll out this sort of the 670G technology, that you're seeing the same things that the pivotal studies showed. So with the 670G pump, you've essentially got 2 modes you can run the pump in. The first is manual mode. I was in Los Angeles at Medtronic only last month, and they over there are not as familiar as we are with the 640G pump because we've had this for quite some time. We've got very good at using it. So we're all across suspend before low, a feature of the 640G pump. So you can essentially, in my mind, you can run this pump just as a 640G pump, or you can turn it on to the 670 capacity, which is really running it in auto mode. You can see the different screens there, that when in manual mode, you've got the glucose trace. When you're in SmartGuard auto mode, you've got your blood glucose level and the arrows telling you whether you're up, down, or sitting nice and even. So when in auto mode, the overall goal is obviously to remain within the time in range, so 3.9 to 10 millimoles per litre. There's an algorithm that the pump is using to essentially target 6.7 millimoles per litre. That's not something you can change. It is hardwired into the pump, and the reason for that is to ensure that that target range between 3.9 and 10 is being met. So micro doses are delivered every 5 minutes by the insulin pump according to the glucose fluctuations and also how long it's been out of range for, or how far away it is from the 6.7 millimoles per litre and for how long. So the algorithm is essentially taking those things into account and then aiming to get to that target of 6.7. It's not going to be able to take into account carbohydrate counting and patients' meals. So that's a very important part of using the 670G technology, is ensuring that meals are bolus for pre-meals to give the best chance of remaining within the time in target. You can set a temporary target of 8.3 if you want, and that might be something that patients might want to do when they're exercising, or perhaps when giving a public speech, things like that, when they just want to increase that target a little bit more to give them a bit more room to move. So the key learning here is that auto basal is adjusted by an algorithm, and it's based on the current sensor glucose, and it's intending to push down to the 6.7 or up to the 6.7. You can run the pump in manual mode, and it is not affected by basal rate settings that are within the pump. It is using an algorithm to make those decisions. Just to recap, what we've got is the pump that is essentially using the algorithm of current sensor glucose, how far it's away from the target, how long it's been away from the target, and how rapidly the glucose level is changing. The insulin feedback, it also takes into account how much active insulin is on board. So, of course, that's important if someone's just had a meal and bolused. And the maximum amount of autobasal that can be delivered over a period of time is taken into account also, such that if a very high amount of delivery is being given, it'll ask patients to verify that the blood glucose level is high. So the key learning here, the algorithm calculates the autobasal using the above parameters. It doesn't learn an individual's time of day pattern, like the time that they might exercise. It's simply taking into account an algorithm based over of the last sort of 7 days. So what does the algorithm do? What does the clinician do? So the basal rate's determined by the algorithm, as I've pointed out. The carbohydrate rate at meal times, that's something the clinician needs to work with the patient to work out the right carbohydrate ratio for those meal boluses. The sensitivity factor is now not controlled by a setting that you put into the pump. The algorithm determines it. The clinician can decide whether the insulin delivery time is 2, 2.5, 3, 4 hours. So that is something that you can adjust in the pump. And the targets, as we pointed out, is really 6.7 most of the time, or 8.3 if you want to take that temporary target up. The factors that have the largest impact on glycemia are going to be the carbohydrate ratio and then bolusing before meals. I think if there's 2 take-home messages for patients who are considering 670G technology, it's firstly, are you willing to do what the pump tells you to do? I.e., if it asks you for a blood glucose measurement, can you do what you're told? And secondly, is can you bolus before meals? So those 2 things, if you can do those things, you're really going to be set up to do well with this pump. Of course, just to remind people that if the pump is pushed back into manual mode, like the 640G, the settings do need to be kept up to date. So that's of course particularly important if you've got children or patients who are changing weight, things like that, to ensure that those basal rates are kept up to date. So hypoglycemia and problems are avoided if they push back into manual mode. So in terms of a successful transition to auto mode, this first one is absolutely the cardinal rule, I think. There really needs to be a big buy-in from the patient. The patient needs to be engaged in ensuring that this has the best chance of working really well for them. So they have to be willing to give blood glucose measurements, formal blood glucose measurements, to equilibrate with the sensor glucose, and also listen to alarms and alerts. So if the pump alerts to needing a BG measurement, say the blood glucose level is above 16, it'll want to confirm that with a formal blood glucose test. Then if that is ignored, then that is when the pump will then fall out of auto mode and push back to safe mode. Understanding that glucose levels are not going to be perfect, so it's not as if you're going to be running 6.7 all the time. It's aiming to get into that timing range. So anywhere between 3.9 and 10, that's the expectation to have. Follow routines and protocols, so be willing to check blood glucose levels 4 to 6 times a day. Once you've done this for a while, then it's pretty good chance that you'll be able to BG test 3 or 4 times a day and get the most out of the time in range. Entering carbs and blood glucose readings before meals is also really important. If you've already started a meal and then decide to give your bolus halfway through it, that'll give you much less chance of remaining within that time in range. And of course, then the pump is likely to ask you for a BG measurement to confirm. Uploading the pump and reviewing CareLink reports is also really cardinal to making the system work. So, for example, reviewing that carbohydrate ratio, making sure that that doesn't need to be adjusted. Quite frequently, once patients are in auto mode, it is becoming pretty clear that their carbohydrate ratios need to be reduced. Important concept is maintaining a close partnership with the patient and the prescriber. So when a patient goes on to auto mode, I would absolutely recommend that their CareLink report be reviewed in a week. That therefore means that they need to know how to upload to CareLink, and that there's a key follow-up plan in terms of then feeding back information from the prescriber to the patient. I'm going to now move on to a case study of Mary. So Mary's a 21-year-old. She has had type 1 diabetes for 6 years, and her HbA1c is, I think, average at 7.8%. She admits that she forgets to bolus a fair bit. She'd like to improve her control, and she'd just like to be normal and not have to focus so much on her diabetes. She's been on an insulin pump for 4 years, and she's transitioning from manual mode and continuous glucose monitoring over to auto mode. So we've got the first week of data of Mary on manual mode, and then you'll see the switch onto auto mode. So this is an overview of that switch over the 2-week period. We can see that because up here we've got the time frame of saying this is when we're looking at over the 14-day period. We can see now the trace over that 2-week period with a fair amount of variability. If we did have a comparator group, perhaps it was a month ago or 3 months ago that we were comparing to, we would see that coming into the background in orange, but because she's new to the system, we're only seeing the blue trace here. If we also had a previous time frame to compare it to, we would have this B here, indicating what the time in range was previously. Here we can see during her 2 weeks that the time in range is 63%. She's having a minimal amount of hypoglycemia, and we can see that when that's happened, it's been somewhere around these sorts of times here if we look at that graph. We can also see that the CareLink is picking up hypoglycemic patterns, 1, 2, and 3. So we can see that there's that low rate in there and also overnight. And then we can come over here to some of our statistics and say, well, it's no surprise she was in manual mode. We knew that for quite a bit of time of this data that we have here. 60% is in auto mode, which is when she switched over. And she's been very good at wearing her sensor 97% of the time. We can now then go on to a daily, sort of a weekly view with day-by-day traces demonstrated here. So where the black is, you can see that this is when she's in manual mode. So anytime that the patient returns to a manual mode, it'll come in with a black strip on the top. So what you can see here is there's quite a lot of variability, swings going up and down and all over the place in a very jagged type of fashion that I think many of us have seen with our patients. And then she's switched on to auto mode here. So the very first day, you can see that there's quite a lot of tightening going on overnight, even that very first day, but still you've got lots of sawtoothing going on Saturday when she's just switched over to auto mode. You can see now the trace on the bottom here of the insulin delivery, previously in manual modes. These are the boluses demonstrated here. And then she's on auto mode where you're seeing these lots of little purple lines indicating how much insulin delivery is being given. As she goes along in the second half of the fortnight, you can see again that this nice tight level overnight is certainly a feature of what she's experiencing over this first period of being on auto mode, but the variability is still great. So why is that? This is a very helpful part of CareLink to review, and this essentially is looking at the boluses at breakfast, lunch and dinner and overnight to sort of look at whereabouts she's actually bolusing. So importantly, I think with Mary is, if you go back one slide here, you can see she's actually not someone who's having a lot of breakfast. So she's not really doing a breakfast thing very often. In fact, she's often coming in late to the piece and doing a sort of brunch is how I would kind of refer to it. And then she's doing a proper dinner where there's this wild variability. So let's have a look at dinner because that's when she's more consistent with when she's eating. And you can see that this line here demonstrates her average timing of her bolus. So already you're on the upswing of the glucose trace, demonstrating she clearly hasn't pre-bolused for most of her dinners. Where we would like to see Mary move is to coming back here to a pre-dinner bolus. Lunch and breakfast in Mary's case are less easy to interpret, partly because of the timing of which she's eating. If you had a timing of lunch that was always 12 or 1 o'clock, you would see that more clearly there at breakfast and lunch. But if you look back again, you'd see that that's the same trend is happening at where she's eating in the morning, and she's often doing a bolus, as she's, after she's eaten, she's already started eating, and then she's bolusing a bit late. So 3 weeks after she started on auto mode, this is what we now see with Mary's profile. That nice overnight area is again demonstrated. So she's definitely doing very well overnight. She's still got a bit of noise going on around sort of the middle of the day, but she's doing much better with dinner, and she's definitely bolusing much more frequently before dinner. That's probably a consequence of lifestyle. She's remained in auto mode most of the time. I just wanted to point out, if we can go back a couple of times, just to show you also the breaks in her auto mode. You can look at these and say, okay, there's not very many. She's done very well at managing herself in auto. It hasn't been swapped to a safe mode very often. But if you look at 1 and 2 here, you can come and see what those exit reasons are. The first is that there was a high blood glucose level, and this was over 1 hour that it was high, and she didn't give a BG test at that time to confirm that it was in fact high. If she had have done that, she wouldn't have come out of auto mode. The second was an unidentified reason. That really probably doesn't count too much. The bottom line is she's maintaining herself in auto mode because when she's being asked, she's actually giving a BG measurement, a finger stick, alongside the sensor when asked. So that's why she's being able to maintain herself in auto mode so well. So I think you'd all agree that that time in range is now a lot better than where she started. She's almost moved herself up to sort of 70 to 75%, which is what I would sort of advocate most patients should be trying to achieve. But she's moved up quite a lot from where she was before. And in fact, now there's absolutely no red. So she's not in hypoglycemia ever now, which is really great news. You can see then that that overlay of the weekly review, again, just picking up on the times when she has exited from auto mode. And again, most times that's going to be when the pump has asked for a BG measurement and it hasn't been delivered. And so you can just go through with your patients. If you're getting a lot of those, that's something to address. Again, the 2 cardinal rules. The first is do what the pump asks you to do, give a BG measurement when it asks for it. And the second thing is bolusing before meals. So Mary's definitely doing pretty well, I would say, at this stage with her insulin pump therapy. Again, seeing here that she's doing much better with the pre-bolusing, particularly at dinner time. All right, so Sonia, you've got a couple of questions for me. So yes. Should we move on to that?
Yep. Got a couple of questions from our audience. Did you want to flick that? Why is 6.7 the target? It seems high.
Okay, so hopefully I did address that in one of my slides, just in terms of what the purpose of the 670G technology is actually to remain within time in range. So the idea is to be between 3.9 and 10. It's not specifically aiming at one particular fine line. So in order to be between 3.9 and 10, obviously the mean there, you get 6.7. That's where the target is setting at, really to stay time in range. So rather than fixing so much on, the pump wants to be at 6.7, it's more thinking about time in range. I think that's what you want to be taking away from this.
Great, thank you. Another question from the audience. What if my patient is pregnant or gets pregnant?
Okay, I see a lot of patients who are either pregnant or planning to be pregnant. And so I think, referring to that previous question, clearly if you're pregnant, a target of 6.7, or should I say more correctly, a time in range of 3.9 to 10 is not going to be adequate enough. That's not going to bring you where you want to be when you're pregnant. So the bottom line is, with this question, is that really if you've got someone who is pregnant, the 670G is the auto mode is really not for them. It's not registered for use in pregnancy, and I certainly wouldn't advocate for it either. So essentially then, if someone's got a 670G pump, it might have been helpful to get them closer to an HbA1c target for pregnancy in leading up to their pregnancy. But once pregnant, and even perhaps a couple of months before pregnancy, you might be wanting to just switch over to that manual mode, that 640G style of manual mode where you've got to suspend before low, but you're not in auto mode.
Okay, great. Another question, can you set the temp target longer than 12 hours? If so, how?
Okay, so I'm just trying to think about where this question is coming from. Most times out of 10, you're not going to want to set the temp target for longer than 12 hours because it would be you're going to exercise for the next 4 hours or couple of hours, and then you're going to be there's potential for you to be in a lower glucose level after that. So perhaps you want to keep it on for 4 or 6 hours, that kind of thing. Maybe you're doing a talk again. If you're doing a talk, maybe you wanted to send it to a temporary target. I would suggest that most times you're not actually going to want to run it for longer than 12 hours. I had a patient the other day ask me, he's planning to go and do lots of hiking in India, I think. So if he's going to do that, should he be in temp target for 12 hours, 24 hours, weeks? And actually the answer to that is probably no. He's probably better to remain with the usual target of 6.7 so the pump can then learn that actually his insulin requirements have changed. And so it's actually taking into account those changes rather than trying to keep it at a higher level. But if the question is, could I do longer than 12 hours? The answer is actually yes, you could. It's just you'd have to keep on putting yourself back into temp target every 12 hours.
And you mentioned you spent some time in the US doing some training. Do you want to tell us anything about that?
Yeah, oh, look, there's heaps, obviously there's heaps more experience over there in the US because they've had the 670G for longer than we have, because we've really not had it for long here in Australia. So they had lots of good little take-home messages. Look, I think the resounding theme though is this is going to be great technology for a patient who is engaged with their diabetes. It's not going to be something for someone to be, I just want to set and forget my diabetes. That's not the sort of person that's going to do well with the 670G technology. It's someone who really wants to make good changes and give a lot in, especially initially getting those rights, getting yourself into auto mode most of the time. Yeah. What else? Yeah, and again, just pre-bolusing, that is an essential part of succeeding with the 670G technology. And finally, I had an experience of wearing the pump for a little bit of time. You've got to do what it says. If you're in a meeting and it's going to go longer than 90 minutes, that's when it would flick you back into safe mode. So you've essentially got a 90-minute grace period, I suppose you could think of, to respond. So it's not like you've got to whip it out and respond right when you're in the middle of a talk, but you've got to get there in the next 90 minutes, otherwise you will pull back into that safe mode. And the safe mode is essentially that's not going back into manual mode. That's actually going to be a mode where it's taking into account what that 24-hour delivery is. So it's essentially an algorithm-derived safe mode, and it's going to stay like that for a little bit of time. Otherwise, you will need to push back into manual mode. When you're in safe mode, you don't have the ability to set a suspend before low. So that's really important for patients to know. So if they're not going to be able to respond to a BG test being asked for, they've got to remember that if they're going to safe mode, they don't have the backup of suspend before low.
Great. Well, I think that concludes our webinar today.
Great.
I might just put that final slide up, the disclaimer one. Thank you for your time today. That's been very insightful, and I'm sure the audience will find that
I think we've got exciting times ahead too in these early days of the Australian experience with the 670G technology.
Yep. Thank you.